So friends, I'll be talking on incisional surgery for astigmatism correction, and I'll talk about LRIs, which are very helpful tool to reduce astigmatism. It is one of the methods you can do and avoid probably the toric IOLs for up to 1.5 diopters of astigmatism. And if you're sitting in a periphery or you don't want to to charge more to the patient and be little conservative, these procedures are absolutely wonderful for your patients and yourself. The results are, I can tell you, they are very much predictable, they are very accurate, and you will never go wrong when you practice these things. I've been doing keratotomies for a very long time. I started in 1988 and might have done more than 200,000 keratotomies in my practice initially, which I now shifted entirely to laser, but still practice keratotomy for high astigmatism and still do all these, especially for the cataract patients where the results are absolutely fantastic and you can manage a huge astigmatism. Sometimes you can manage up to 2.5 astigmatism, because the result for a elderly patient is much more than a younger patient of 18 to 25. When you're talking of astigmatic correction in a patient age 60 or above, the results are much superior. Okay, so let me start with LRIs, and Oyakawa showed 96% success rate, and I can vouch for it. And this is very important. The LRIs can be, by adjusting the length or depth or location of the arcuate incision, one can induce changes, and changes in the corneal astigmatism are achieved by flattening the steep corneal meridian with a simultaneous increase in the corneal curvature in the flat meridian. So this is very important. This is called coupling, and when you're treating a high astigmatism, you must consider and take into consideration the fact that the result will be nearly double, and LRI should be as peripheral as possible, thereby elevating the corneal astigmatism, while keeping the average corneal power untouched. Oh, you can come here, sir. Excuse me, you can sit here. There's no problem. There's a seat here. And so the corneal power remains unchanged. So the IOL power need not to be changed when you are correcting the astigmatism. This is the beauty of the whole system. So IOL power doesn't change, only the astigmatism changes, and the advantage is almost immediate recovery, excellent quality. Next day the results are visible, and they are often combined with cataract surgery, and especially useful in premium IOL in patients with over 1 diopter of astigmatism, and this is absolutely wonderful. Now, Louis Nichamin, his an age and pachymetry adjusted intralimbal arcuate astigmatism nomogram is one of the most widely used nomograms, and NAPA is being practiced for over 35 years now. It's a wonderful nomogram. The only important factor is corneal pachymetry. For any incisional technique, you have to have a wonderful absolutely accurate pachymetry, so that you achieve 90% of the depth, do not perforate, and remain 90%. The effect is only there if you reach 90%. If it is only 50-60%, there will be no effect at all. So this is very important. They are simple, but many surgeons are still hesitant. The important thing is you select the proper table and do a proper pachymetry, and in thicker corneas little overcorrection is required because the effect is lesser. So this is the NAPA nomogram. Whosoever wants, kindly take a picture, and then you will see that these are the nomograms where you can achieve a really nice result in, this is age modified size of the incisions, peripheral incisions, where you can take it and do a astigmatism correction in all your cataract patients, especially where the power is, you have astigmatism in the range of 3 diopters or 2.5 diopters. It's a wonderful tool to avoid toric lenses. Sometimes the toric lenses are not also available, or if they are available, they are too expensive, or you take a lot of time in getting them. So this is very important. I'll change the slide. If you have not taken the picture, let me know, otherwise I'll change the slide. Yeah, thank you. Okay, back. Okay. Okay, sir. So this is the nomogram. This is not very important. This is the important thing is that there is a area where you have a size of the incision, and that you have to calculate. Now, astigmatic keratotomy is important, especially when the corneal transplant and radial keratotomy surgery both stimulated development of astigmatic keratotomy, because it is useful for numerous refractive problems like congenital astigmatism with a cataract, post-traumatic, after corneal transplantation, and even now after the laser correction surgery, when there is a lot of astigmatism, or astigmatism is residual astigmatism you are seeing, then also you can do it. So there are 4 schools, and we cannot continue, but there are so many people who have worked on astigmatic keratotomies: Norden, Richard Lindstrom, Thornton, Shire, and such people. And they have actually, Shire especially, he has done so much work on excimer laser astigmatic correction, and PRK, repeat PRK, and on the table keratometry reading and doing PRK, further enhancement of the PRK in the single sitting only. And as I have already told you, about the Nichimen and coupling, I already discussed that there is, then when there is a tangential or arcuate incision is placed, 2 events occur along the meridian of incision. Central to the incisions, flattening of the cornea occurs, and commensurately the meridian 90 degree away steepens. The combination of flattening and the steeper axis and steepening of the flatter axis yields the total amount of astigmatism correction, which is 1.5 to 2 times, and this is what is used in majority of cross compound correction with the excimer laser, where you correct half of the astigmatism with minus correction and rest of the correction with the plus astigmatic correction, especially in the Nidec excimer laser. So indications of astigmatic keratotomy, as I have already discussed, but the important indication will be in the case of multifocal IOL, and contraindication is rheumatoid arthritis, dry eye, chemical burn, and especially diabetes and hyperopia, of course. And the other things I have already talked. Longer the incision, more is the effect. Smaller the optical zone, more is the effect. Less uncut tissue after knife tip, the greater the effect. So deeper the incision is, more of the effect. That is the last point. And this is okay. So normal age what we take is 50, and increase 1 degree for each year below 50. That is the change in the size of the incision. So 1 diopter you correct 80% degrees, and like that go up to 3 diopters. You can go up to 3 diopters using a 160 degree incision. And let me see if this works. Yes, hopefully it will. No, it is not working. So anyway, for more precision, there is a femtosecond laser which gives you exact size, place, and depth. And this is the incision LRI performed with the excimer laser. This is the most recent case, about maybe 10 days back, when I did it, and I took a recent picture of this, So the laser nomogram is also there. If you have a laser, then you can have a nomogram for the laser which is supplied with the laser, so there is no need to, these are not manual things. And the femtosecond arc incision are adjustable. These are the beautiful part of this incision, because if there is less effect you can open it again. If it is high effect, then you may not open, you can make two incisions. If you have sufficient effect after opening one incision, you may not open the second one. And safety is that because they are monitored with the OCT. And intrastromal incisions are there, which are done with the femtosecond laser. And Donenfeld nomogram is there. If you have a femtosecond laser for performing the intrastromal incisions, then you can use this nomogram. So this is the system for the femtosecond laser. And of course intrastromal, there is no epithelial defect, so there is no pain, no loss of cold sensation, less dry eye, no need of antibiotic, but they are less effective. And this is a laser arcuate incision which you can see here. There are two incisions, one is here. Because of the bubble effect, you can see them. So the complication, foreign body sensation, overcorrection and undercorrection, they can be managed depending upon what you want to do exactly. You can suture them or you can open them. And late regression of result is possible, which can be managed, of course. And serious complication is because if this incision size is too central, there is loss of visual acuity because of the irregular astigmatism which it can create. Thank you very much.